Hello, everyone, and welcome to the session of Pallium Canada's ECHO program. And looking at the number of people that are joining us, we're into 250 and over and climbing. Obviously, there's a lot of interest in this area. And today we're going to be exploring psilocybin in palliative care and looking at its history, the evolution, definitions, and some of the legal landscapes. And to help us with understanding all that, we've got a fantastic panel of experts that we'll introduce you to very shortly. But first, let's go over to Diane Vince in the office of Pallium to do the territorial honoring.
Thank you so much, Jose. Before we get into our presentation, I would like to take the opportunity to acknowledge that the land on which I am presenting from, the city of Ottawa, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge, and we acknowledge, the historical oppression of lands, cultures, and the original people in what we now know as Canada, and we are grateful to have the opportunity to be present in this territory. Briefly about the Palliative Care ECHO Project, it is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for their patients with life-limiting illness. We invite you to check out our website. A link has been shared with you in the chat at echopalliative.com. The Palliative Care ECHO Project is also supported by a financial contribution from Health Canada. Therefore, the views expressed here today do not necessarily represent the views of Health Canada. Many of you might know Pallium for our LEAP courses, our LEAP programs, predominantly our LEAP core, one of our best-selling courses, interprofessional course that focuses on the essential competencies to provide a palliative care approach, taught by local experts who are experienced in palliative care clinicians and educators. We invite you to check out our website. Once again, a link has been shared with you in the chat to learn more about LEAP Core, and it is double accredited with the CFBC as well as the Royal College. I will now pass it along to our host and the presenters to allow them to present themselves.
Thanks very much, Diana. So again, welcome from coast to coast to coast. I think there are people from right across the country and even internationally, and we're seeing more and more with our sessions that we're going broader and broader afield. I'm coming to you actually from Spain, where I'm doing a stint there. I'm professor in the Faculty of Medicine at the University of Navarra in Pamplona, known for the bull run, which I promise you I will do not do, and I will never do it. I'm also professor in the Division of Palliative Care in the Department of Family Medicine at McMaster University, and scientific advisor and co-founder of Pallium Canada. And Pallium Canada is now into its 24th year. I'll be the host today, and let me start the introduction of the presenters. So Jean, you first up on the screen, so I'll hand over to you. If you could please present yourselves in the order that appears on the slide. So Jean.
Thanks, Jose. I'm Dr. Jean Mathews. I'm a palliative care physician and assistant professor in the Division of Palliative Medicine at Queen's University in Kingston, Ontario.
Thank you. Ronald.
Yeah, good afternoon. My name is Ron Shore. I'm a research scientist within Queen's Health Sciences, and my specialization is on psychedelics and psychedelic trial design in particular. And I'm also an assistant professor in the Department of Psychiatry at Queen's, and as such, we are involved in a clinical trial of psilocybin for alcohol use disorder.
Thank you very much. I know Jean's been previously on some of the ECHO programs, especially the Journal Watch. Ron, I think this is first for you, so very, very welcome to the Pallium ECHO project. Then over to our other panelists. Kylea, please, if you could introduce yourself.
Hi, good afternoon. I'm Dr. Kylea Potvin. I'm a medical oncologist at the Atlanta Regional Cancer Program and an associate professor at Western University, and have been doing what I can to learn and train in this wonderful transformative space to try to help build a community of practice where I am in London. So it's a great pleasure to be here learning with everyone today.
And thank you as well. Thanks for joining us. And then to two folks who I've previously had the privilege of working with, first Geneviève and then Lyle. So Geneviève.
Yep. Oh, hi. Hi, Jose. Thank you. I'm Geneviève Lalumière. I'm a clinical nurse specialist working with the regional palliative consultation team in Ottawa, although today I'm in Calgary. I can't say I have a great expertise in the topic, but definitely I'm interested and somewhat informed. I've also applied to one of the Canadian universities to take the psychedelic assisted therapy program. So hopefully next year, this time I'll be more informed. But I'm also working with the Division of Palliative Medicine in Ottawa and the broader palliative care program to see if we could get a psychedelic assisted therapy program running in Ottawa. Yeah, so that's me.
Thank you.
And I'm Lyle Galloway. I'm a palliative care physician in Calgary. I am medical lead for our pain and palliative consult team at the Cancer Center. I also do some inpatient work on our IPCU, which Jose founded back in 2001. I did training with CIAS in psychedelic-assisted therapy and research 3 or 4 years ago. And since then, it's been a certain part of my practice. I've been involved with the majority of the Alberta patients who had Section 56 exemptions back in the day, and we're working our way through the current SAP process that we'll hear a little bit more about.
Yeah, great, fantastic. You're throwing out some legalese there that you'll need to explain. Section 56 and SAP. So looking forward to learning.
It's all coming up.
Very good. Fantastic. I'm recognizing quite a few names as they come on to the chat. So very welcome. Amy, great to see you. Gary Frank, great to see you again. May I ask you if you've got, so we've seen the introductions on the chat with everyone. When we get to the actual session, could you please post your questions and comments using the Q&A function, please? So use the Q&A instead of the chat. It's easier for others to see the responses. Very quickly, conflict of interest declaration. Overall, Pallium Canada is a non-profit organization. Over the years, has been funded at times by contributions from Health Canada, and as you heard earlier, the ECHO program, which is what we are participating in today, is funded by Health Canada, and Pallium also generates funds through support operations and course registration fees and licenses for its LEAP courses. I do get stipends from Pallium Canada, and Ronald, Dr. Shore is declared here currently owns shares in a psychedelics-oriented retreat center. Jean has got nothing to disclose. Geneviève and Lyle, any conflict to declare? No. Good. And Kylea, any conflict to declare? No. Very good. So again, use the chat, use the QA function for questions. The session is being recorded, and this recording and the slide deck will be emailed to registrants within the week, and will also be made available in a few weeks' time for other folks to sign on and download and hear and what you have to say and share with us today. Remember not to disclose any personal health information during the session, please. Good. Getting closer and closer to the meat of it. And so starting off, I'm not sure who's going to start off with this Jean, wasn't it?
Yes.
Thank you.
Thank you. Thank you,
Over to you.
Thank you. Okay, so these are the topics that I'm going to cover in the next 25 minutes. So we'll start by describing the problem we're trying to address in patients living with a life-limiting illness, that is the problem of existential distress. I will very quickly review the current evidence for what are the currently available treatments, both psychotherapeutic and psychopharmacological, and how we in our practice try to help patients who are having this distress. And then I'll get into a critical appraisal of the evidence for psilocybin in palliative care. That's going to be the kind of the meat of the talk. We're going to cover the 3 main kind of randomized controlled trials of psilocybin in palliative care. And I'm going to approach this from the lens of, I'm not a psychedelics researcher or scientist. I'm a palliative care clinician who cares for patients with life-limiting illness and existential distress. So what I want to know is two things. Are the patients who are included in these trials representative of the patients that I see in my practice? And then are the environment in which these trials are carried out feasible for me to replicate in my practice? And both of these questions I encourage you to ask related to your own palliative care practice, because this is important when we appraise this literature to know because how we interpret the literature and its applicability in our practice is based on the answers to those questions. And that leads me to the concept of what is called efficacy effectiveness gap. It's a concept some of you might be familiar with in the oncology drug trial literature. It's this idea that if you look at the cancer drug trials, you see quite impressive efficacy of cancer drug trials in treatment response or survival. And then when that is translated to a real world context, we don't see the same level of effectiveness. And the main kind of reasons attributed to this is we know that the patients who participate in these trials are called the Olympians of cancer patients. So they're patients who are much younger, much more fit, less comorbid conditions. They're able to tolerate higher doses. And then the environment in which those trials are conducted, there's much more close monitoring with nursing calls, regular blood work, scans, and this patient factors and environment factors, if they're not translated to our real world practice, you might not see the same response. This idea is common in oncology trials. It's common in our palliative care trials. So it's nothing that's specific to psychedelics or psilocybin research, but I want to approach this from this lens of what can we learn that we can apply to our own practice. That'll lead to a discussion of our limitations and kind of future directions in this area of research. Okay, so the problem, it's existential distress, which is mental distress experienced by those facing imminent death, and it's associated with demoralization, loss of meaning, hopelessness. It's also known as death anxiety, demoralization, hopelessness, etc. We know it's quite prevalent in our patient population, and it's associated with poor quality of life, increased healthcare utilization, requests for hastened death, decreased survival, and so on. So it's an important problem. The currently available treatments, I'll talk about both psychotherapeutic and psychopharmacological. And obviously, this is not an exhaustive list, and we could spend an hour just talking about any one of these. But I'm just going to highlight the randomized control trial level data that's available. So we see here some of the approaches. Dignity therapy, this was Chochinov and colleagues in 2011. They published a landmark trial of this. Cognitive behavioral therapy, meaning-centered psychotherapy, calm therapy. This was developed in Toronto. And then specialized palliative care on its own is a therapeutic intervention. So when we have advanced care planning conversations with patients, that's a form of supportive therapy. When we help patients navigate end-of-life health systems and community supports, that's a form of problem-solving therapy. So specialized palliative care has been studied as a dyadic coping intervention for patients with existential distress, and there's RCT level evidence of that as well. The last Cochrane review for this was done in 2008, so I'm going to point you to something that's more recent. This was published in Psycho-Oncology in 2018. It's a meta-analysis of therapeutic interventions for existential distress. They looked at 30 RCTs. You can see here the different types of therapeutic interventions. And what they found was an effect size in the range of 0.3 to 0.5 effect size. And this is something I'll come to later as well. So to put that in context, 0.2 is considered a small effect size. 0.5 is a moderate effect size. 0.8 is a large effect size. Most of the psychotherapeutic and psychopharmacological interventions currently available for existential distress are in the 0.3 to 0.5 range. And if we compare that to psilocybin and psychedelics in general, I'll show you later on, it's an effect size of 1.2 and higher. So much greater effect sizes. And then the other point to think about is a lot of these interventions, they take months to see the effect, and the follow-up in the medium and long term in these trials were scarce. Okay, and now coming to the psychopharmacological interventions currently available, these are kind of familiar to all of you. And this was the last Cochrane review. This was actually done last year, looking at 14 RCTs of antidepressants, and they found that there is some evidence to increase or to reduce depressive symptoms. No studies reported on data of follow-up more than 12 weeks, and they weren't able to recommend one particular intervention over others. Okay, so that was a very rapid kind of review of what's currently available solutions. Now we'll talk about psilocybin specifically, which is a classic serotonergic psychedelic. Found in several mushroom species, metabolized to psilocin, which is a potent agonist at 5-HT2A receptor, and this activation is correlated with the hallucinogenic activity. And how does that translate to positive outcomes? So this was a randomized controlled trial from Griffiths and colleagues in 2006, where they gave 30 healthy volunteers either 30 milligrams of psilocybin or methylphenidate, something we commonly use for cancer-related fatigue. And then they measured drug effects and mystical experience immediately after and then 2 months later. And they found that psilocybin, as expected, would produce a acute perceptual change in mood, as well as increased a mystical experience. And at 2 months, all the participants reported a substantial personal meaning and spiritual significance to the event, and that was correlated with the mystical experience causing a sustained positive change to attitudes and behaviors. So the three kind of major trials of psilocybin palliative care, I've listed them out over here, and we'll go through each one in more detail, critically appraising from the perspective of palliative care clinicians what we need to know to impact our practice. I'm also showing or just listing a fourth trial there. This was Anderson 2020. This was a group psilocybin-assisted therapy for demoralized older adult long-term AIDS survivor men. This was an open label safety and feasibility pilot study. I'm not going to more details because this was for people with a survival more than 2 years. So it was prognosis more than 2 years. So it's not the typical population we see in palliative care, but I've just listed it here for those who are interested in looking further into that. Okay, so we'll go through the first trial. This is GROB 2011, pilot study of psilocybin. It's 12 patients with advanced cancer and anxiety. What's important to note, 67% of those who were included in this trial had reported previous psychedelic use, and I'll come to this in the later trials as well, and I'll tell you why this is something important to consider when we appraise this data. They received either a moderate dose of psilocybin plus psychotherapy or niacin plus psychotherapy. Niacin as an active placebo has some warm tingling type of sensations, might help with blinding. That was the rationale for that. You can see here the exclusion criteria. So any abnormal hepatic or renal function, diabetes, and you can see a bunch of medications there. And this is another thing we look at. The more exclusion criteria, the more strict these trials are, it's harder to generalize to our real world patient population. Because this was a feasibility study, safety study, the primary outcome was safety and adverse psychological effects, and they look at secondary outcomes for mood. And they reported that the trial showed that it was safe and improved anxiety at 1 and 3 months and improved depression at 6 months. Coming to the next study, this is the Griffiths 2016 study, again with psilocybin in patients with life-threatening cancer. That's a point I'll come to later, when how we actually define life-threatening cancer and whether this is the population that we see in our practice. So this was a crossover trial design. So either they received a low dose, 1 or 3 milligram, or a high dose, 22 or 30 milligram, of psilocybin, and then there was a 5-week period, and then there was crossover depending on which arm you were in. And then they followed these patients for 6 months. So 51 participants, mean age was 56. Is this the mean age of the people that we see in our practice? It isn't for me. In my palliative care clinic, the mean age is closer to 69. And obviously, with age comes more comorbidity, and you have to think about whether you will see the same effect, the same tolerability of the drug and things like that. 49% female, 94% were white. This is a common kind of critique in not only psychedelic trials, in palliative care trials, that there's less diversity. Again, about half reported past use of hallucinogens. The reason this is important, one, if a participant has used a hallucinogen before, they're probably familiar with the effects of it, and it's more hard to blind them. So they'll recognize when they get the same effects again. And second, it can cause expectancy effect. So if you know that a hallucinogen has a particular effect, you expect that effect. And then if you get the intervention, you'll be happy you got the intervention, and you'll report your subjective outcome possibly in a biased way. And if you didn't get the intervention, if you got the placebo, you'll be sad or you'll be angry that you didn't get the intervention, and you'll report possibly a biased or worse outcome. And this can inflate the effect size. That's why this is an important thing to consider. 27% had metastatic cancer with prognosis less than 2 years. Is this what you see in your typical practice? Not for me. In our practice, 90% of our patients in our cancer clinic will have metastatic cancer with a prognosis less than 2 years. And again, this is important for reasons I stated earlier. The real kind of impactful finding, at 6 months, more than 75% of the high dose group showed more than 50% reduction in depression and anxiety. That was their predefined kind of clinical endpoint. There's no intervention that we have currently, either psychotherapeutic or psychopharmacological, that after a single dose can produce an immediate and significant and sustained response like this. And that's a real impactful thing to think about. So the mystical experience was a significant mediator of the therapeutic response.
Jean, it's Josiah. If I could just jump in very quickly,
Yes.
because I'm trying to track the questions coming in. Anik asked about the dosing. So if you go back to the previous one, please. The dosing, for those of us who don't know much about this, when you, am I correct in saying then they receive the treatment every 5 weeks? Or perhaps if you could explain what you mean by counterbalanced sequence.
Yeah, so it was a crossover trial. So you were randomized to one of two arms. The first one arm received a low dose. So they started at 3 milligram, and then they found that the 3 milligram might have an active effect. So they backed down to 1 milligram. Or you get the other arm, which is the high dose arm, which is 22 or 30 milligram. They started with 30 milligram, but then they noticed that a couple of patients didn't tolerate that, so they went down to 22 milligram. So you got either one of those, and then 5 weeks later, you crossed over to the other, depending on what you got the first time.
Okay, so you got treatment basically some form of treatment every 5 weeks. And then the study before this, the dose again, was that a one-time dosing or?
That's right. It was a single dose. So all of these were single dose studies.
Well, except for this one, right? Single dose at one particular dose.
That's right.
Got it. Thank you.
The high dose condition was a single dose.
Thank you. Sorry to interrupt.
Oh, of course. Okay, the other point I wanted to make, I said this earlier as well, just looking at the inclusion-exclusion criteria, you can see there's quite a lot of kind of exclusion criteria, and the more you have these, the less you can kind of generalize the results. The final study I'll look at is the Ross 2016. And again, this was psilocybin for patients with life-threatening cancer and anxiety. Again, they call it a double-blind study, but in this study, they actually tested that. They asked the therapists who were present in the room with the participants to guess which arm they thought the participants were in. And out of the 29 participants, in 28 cases, the therapist correctly guessed which intervention they got, whether it was the psilocybin or the placebo. So there are real questions about blinding in this trial design. And again, you got either the single dose of psilocybin or niacin as the placebo in conjunction with psychotherapy. All of these are in conjunction with psychotherapy. So I think that was one of the questions as well. Primary outcomes were anxiety and depression before the crossover, which happened at 7 weeks. Again, if you look at the demographics, we can question whether these are the demographics of the patients we see in our practice. Really impactful, immediate effects. So within day 1, they found a substantial improvement in anxiety and depression, and this was sustained at 6 months follow-up. And then they found that the mystical experience partially mediated the therapeutic effect. I won't belabor the point of the inclusion and exclusion. The raw study, they actually did a long-term follow-up at 3 years and 4.5 years. So out of the 29, 15 participants were followed up. And they found that 71% of those participants were in partial or complete cancer remission. So again, not generalizable to our patient population. They found a sustained reduction in anxiety and depression at that 3 and 4 year time period, and participants rated it among the most personally meaningful and spiritually significant experiences of their life, which is quite impactful. But there are a couple of sources of bias here. One, it's a very small population; it's just 15 people. And the other source is we see that 71% of the participants went into cancer remission. So the thing that caused them an existential threat was removed. So is the reduction in anxiety and depression because of the psilocybin or because their cancer went into remission? We don't know. And then they talked about possible mechanisms in this paper. They talked about the mystical experience, trait openness, and cognitive flexibility as a mediator that could explain why it could cause reduction in anxiety and depression and things like that. Okay, I'll talk a bit about set and setting because that's something important to this particular area of research. Set is mindset. How do you prepare the participant? So each participant meets with, in all of these trials, they were pretty common in the way they described it. They meet with 2 therapists before, which is called the preparation. They meet with therapists during the session. And then there's, after the 8-hour dosing session, there's an integration or consolidation. In the Griffiths trial, there was a mean of 4 sessions of 9-hour duration, and the Ross trial, 6 therapy sessions of 12-hour duration. So this is important to remember when you think about the environment, and can you reproduce this in your practice, to have 2 therapists spending 12 hours with 1 patient. Now, when we talk about future trends, they're starting to show trials of non-randomized trials of group psychotherapy. So this might be a way to make this more practical and feasible. What happens in these sessions? You build rapport and trust, review significant life issues, discuss the purpose and the intention of the treatment, prepare for a range of emotional reactions that might be experienced. So in the Ross trial, they described that participants could get benzodiazepines or olanzapine if they developed anxiety during the dosing session. And then this common kind of idea of trust, let go, and be open. That's about the set. Now about the setting. All 3 trials kind of go into details about the environment. So in Grob, they talk about fabric wall hangings and fresh flowers. In Griffith's trial, they talk about aesthetic living room-like environment. In the Ross trial, they talk again about fresh flowers and fruits. And again, is this something you can recreate in your practice right now? In the last year, there's actually a trial open right now. It's on clinicaltrials.gov of a psychedelic-assisted therapy trial in an inpatient hospice setting. So that's more kind of akin to the settings that we practice in. And they actually use palliative care as the therapeutic modality. So we'll wait to see what comes out of that. The subjects in all these trials are encouraged to lie in bed wearing eye shades and headphones to listen to music and focus their attention inwards. The therapists remain with the participant for the entire 8 hours. And after the session, they're encouraged to discuss their subjective experience to consolidate the memory. Very transient adverse effects kind of reported, some transient increase in blood pressure, which peaked in the 3-hour mark at the Ross trial, nausea, vomiting, headache, transient psychological distress, but no persistent perception disorders or psychoses. I'm coming to the end of my presentation. So this was just a meta-analysis in 2020 of placebo-controlled trials of psychedelic-assisted therapy. This is all psychedelics, not just psilocybin, and all indications, not just existential distress. But I just want to highlight that point of the effect size that I'd made earlier. A significant mean effect size of 1.21, which is larger than the typical effect sizes you find in psychopharmacological and psychotherapy interventions, which are in the 0.3 to 0.5 range. And again, you're getting this with, in these psilocybin trials with a single kind of like a high dose intervention, you get an immediate, significant, and a sustained response, which is quite remarkable and impressive. The limitations, I talked about this, so small sample size. Do these clinical demographic characteristics meet or are they representative of our practice? Blinding was either unsuccessful or not reported. A high percentage of previous psychedelic experience, which can lead to expectancy effects and lead to bias in these kind of effect sizes. We know that there is lacking in diversity, and a lot of this can be true of psychiatry trials in general and palliative care trials in general, and in cancer drug trials as well. You can see some carryover effect in crossover trials, and most of this was private sector funding. What are the future directions? And in fact, I would say in the last year, you're already starting to see some of this. There are non-randomized trials of group psychotherapy. You're going to start seeing larger sample sizes, a parallel group design. There's controversy or what's the best kind of placebo to help blinding, but I think the consensus is a low-dose psychedelic as an active placebo might help. Those participants who are naive to psychedelics, it might help to improve blinding. And they also recommend to measure, are you actually successful in blinding, by asking participants and therapists and assessors to guess what arm they're part of. Using clinician-reported outcomes instead of patient-reported outcomes, or to supplement patient-reported outcomes, can help to improve our appraisal of this literature. Fewer exclusion criteria to make the findings more generalizable. Study the cost effectiveness. So what drives the cost of these trials is actually the psychotherapy, having 2 therapists for 12 hours for 1 patient. So now we're starting to see group psychotherapy, and maybe that'll help to make it more practical and feasible. To study the actual psychotherapeutic intervention on its own. So, studies of dignity therapy or calm therapy or palliative care as the therapy, and the benefit of the therapeutic alliance. So if you can form a stronger therapeutic alliance, does that lead to better outcomes? Measuring therapeutic fidelity. So these are all kind of the future directions where we expect these studies to go. And now I'm going to hand it over to Dr. Shore.
Thanks, Jean. Dr. Shore, just very quickly, I see there's some questions being posted around what is the definition of existential, and also what is the role of spiritual care providers. So what I'll do is I'll ask the panelists to keep in mind those two. If you if you can address those questions, please do so. Again, what is define existential, and then also the role of spiritual care. Stéphane Rivet, for example, says highlights there's a lot of links here, and that spiritual care providers have some of these competencies. So if it comes up in your presentation, please, if you could address it. Thank you.
Thank you. And thank you very much, Dr. Mathews. Excellent. It's very honored to follow up on that. Welcome, everybody. Thank you for inviting me into this. The perspective I'm going to share is from my own direct research. That my PhD is specific to the clinical application of psilocybin, but also my experience as a clinical trial therapist in our clinical trial of psilocybin for alcohol use disorder. And just by way of background, I kind of came of age through the AIDS movement and community health. I've spent a lot of time around death and dying and palliative care, certified in contemplative end-of-life care. So this is a big interest of mine. And as a psychedelic researcher, I'm so pleased to see the palliative space inviting this kind of dialogue. I think it is really well suited to this kind of work, and I think really even better suited than some other areas of psychiatry that are really quickly moving in to psychedelics, because I think palliative care is already a transformative space. So I'll bring a bit of my background there. I'm going to address neurological underpinnings. I'll talk a bit more about medication. I know there's some questions about pharmacology and dosage, so I'll address that a bit. I can touch on the role of spiritual care advisors, and I'll address the legalities as well. So, and we'll be sure to leave time for our panelists and for questions as well. So just really briefly, you can kind of read that, and I'll explain a little briefly in a bit more detail. Dr. Mathews explained that these are serotonergic agonists. So psilocybe genus mushrooms are the origin. Most of the clinical trials use a synthetic version of psilocybin. Both get metabolized into psilocin, as Dr. Mathews explained. It is a potent serotonin 5-HT2A agonist, and serotonin is a neuromodulator. So more than a neurotransmitter, it's responsible for governing a wide range of kind of dissolute processes across the brain and body, and touch on the endocrine system as well. So you get a more generalized effect through these kind of agonists. And as you can see, there's this acute period of what they call cortical desynchronization, where associative kind of dominance, which tends to occur in the default mode network or frontal cortex, that is kind of quieted due to the vasoconstrictive action of psilocybin. But these kind of pyramidal neurons spike high, and so there's a really broad-based desynchronization of network activity. So instead of people experiencing rumination and worry, which is all kind of prefrontal cortex associative activity, there's a quieting of that space and a movement more into sensory awareness and greater connectivity to the limbic system, which governs and regulates emotional response, arousal, memory, fear. And so there's a fascinating process that happens acutely. And then we know through neuroimaging, there's a period of at least 30 days where there's acute persisting neurological, particularly in terms of neuroconnectivity between different brain regions, are affected for up to 30 days. So that explains the kind of afterglow or integration period. It's characterized by heightened neuroplasticity and learning, and also by a sense of long-term potentiation. So memory formation in that time simply has the potential to be stored on a more long-term basis. And so you're seeing this afterglow period at the time of health behavior change for people. So my full reference is from my thesis if people want to dig it up. The interesting thing about this, as much as we're talking about this in a contemporary palliative setting, and it's kind of the wonder child of psychiatry these days, there's an ancient history to this, and it brings us back to our roots in terms of connection to the earth, really. So psilocybe genus mushrooms are globally distributed. We know about them largely because of the exposure of one Mexican curandero named Maria Sabina, a Time Life publication in 1957 called Seeking the Magic Mushroom, contributed to the formation of the counterculture, the LSD project of Leary and Ram Dass. I'm going to touch on that a bit, because as that kind of all processed, a story kind of came into place about how psychedelics worked, and in particular, a therapeutic model. And it's a model known as the peak psychedelic experience. I'm going to talk about that. But we have to remember that we're kind of venturing into areas that medicine is maybe a little bit uncomfortable generally with, areas of spirituality, of consciousness. And we're going back into a long ancient tradition where psychoactive medications were used for ritual purposes, generally as part of a religious rite or some sort of earth connectivity. And we have evidence of sacred kind of psychoactive use, whether it's ayahuasca, peyote, wachuma, psilocybe mushrooms that go back thousands of years. There's cave paintings we can date to at least 6,000 years old that seem to indicate mushroom ritual worship. The mushroom stones of Guatemala are hundreds of stones that are dated to between 0 and 500 AD that really indicate human worship of mushroom deities, because it's very telltale iconography. But we know about this principally because of Maria Sabina. And Sabina was featured in an article by Gordon Watson. She was a Mexican curandera, or sabia, she preferred to be called. She was a shaman. She was a ceremonialist of the Mazatec people. She's poor, and she had originally ingested psilocybe mushrooms as a child, eventually developed a relationship where she could access sacred knowledge and therefore see into the roots of spiritual suffering. and of medical suffering, because in indigenous cosmologies, the presentation of illness would generally be coupled with a spiritual underpinning. So we had to venture into the spiritual space to realize the kind of origin of the disease, which is something that is probably a little unfamiliar to modern medicine. I'll touch just briefly on Eloithus. This is an ancient Greek ritual where it's thought to have lasted up to 1,500 years. Plato, Pythagoras, Aristotle all would have kind of sat in this. It was an entheogenic tea that was served to people. We assume it was a relative of LSD and ergot mushroom that had infected rye, and they'd realized a way to kind of serve it in a way that minimized some of the toxicity. And so there was a ritual. People would drink this brew and they would reenact the myth of Demeter and Persephone, which is the death story, which is the story of winter coming and spring and summer ending. Persephone was abducted into the underworld and rescued by her mother and the intervention of Zeus. And it represented a connection with nature and the rhythms of spring, summer, fall, and winter, which of course is associated with death. So above the gates of Eloithus with the kind of mantra, if you die before you die, you won't die when you die. So there was a spiritual enactment of a rebirth process. So this becomes early on a telltale theme of psychedelic practice in the Western culture. This came out through the 60s and 1970s. So this model has been relatively consistent since the 1960s and later some of the early trials into the 70s, and then reinvented really starting about 15 years ago. And now the number of clinical trials that will publish in the next 2 years is going to radically exceed anything that was published in the previous kind of 50 years. But anyway, a similar model has evolved, and it's called peak psychedelic. It's the use of a high, but not a very high dose of psilocybin. These are all synthetic in the clinical trials. We've yet to see a clinical trial published, but there's some in process using an organic compound. But that's equivalent to about 5 grams of magic mushroom if people want a conversion into naturalistic setting. So we're talking high dose, but not super heroic, because at a higher dose, there's simply higher rates of adverse experience. So psilocybin has a duration of action of about 4 to 6 hours. We keep people for 8 hours during the clinical trial, but most people are kind of feeling generally resolved by 6-hour mark, although there are persisting effects which continue, as I said, up to about 30 days. All of these trials have a curated setting, as Dr. Mathews indicated. There's a high sensitivity to context with psilocybin. People are very sensitive to their environment. So we're very careful how you curate that space. And the contemporary approach is to encourage what's called an internal journey by the use of eye shades and headphones with curated playlists. And the therapist's job is non-directive. We're there to provide support if needed, have some conversation, but if conversation becomes more prevalent than it should be, we're directing people back into their interior journey. It's a symbolic, meditative, contemplative journey inward in which people have the opportunity to review their life. And in our context, we're looking at alcohol use disorder, but I've seen this in palliative settings, and I've seen similar processes. Generally, this distress is marked by fear and anxiety and rumination, worry. And psilocybin just seems to have an ability to kind of suppress the worry a little bit and allow for greater sense of relationality and an experience of spirituality for people. But they're always coupled within, as Dr. Mathews indicated, extensive preparation and extensive integration. My concern in this space is people who don't get enough integration afterward. I think that's quite common. So not necessarily in trials, but in other practices. So we need to worry because there's, again, a persisting effect at least 30 days. So in these trials, psilocybin is always featured as an adjunct, as side-by-side an adjunctive therapy, meaning it was combined with CBT, with acceptance commitment therapy. In our case, motivational enhancement therapy. Trials are using calm alongside it, for example. So it's always, there's a synergistic effect. So one of the limitations is how much is due to the therapist and the therapist impact, and suggestibility is high with psychedelic, and how much is due to the compound. I would argue they're inseparable. They always occur in context. Serotonin itself is very environmentally tethered. It has to do with socialization. Psilocybin returns us to a sense of relationality to the world. The idea of a patient that's separate and it's got mechanics inside that are determining its health falls apart under psilocybin and serotonin, because so much is environmentally related, including, and that's why I said profound kind of sensitivity to context here, what you do before and what you do after really affects the psilocybin experience. And that's why they're called non-specific amplifiers. And we know by now there's known predictors of success or good therapeutic outcomes. And there's things like, as Dr. Mathews indicated, the ability for people to experience emotions and not run from them or try to suppress them or deflect them is super important, probably number one. I'm not a believer that every psilocybin experience needs to be transcendent or mystical, because not all of them are. And I work a lot around addiction. So I don't really work. And if people have SSRIs, there's going to be a modulating effect of the SSRI. They're less likely to have the vision. So in which case, what we have to rely on is the emotional openness that comes with psilocybin. That to me is the therapeutic effect. But we know if they can demonstrate absorption, which is a meditative state of not kind of associating with your thoughts and thinking about thinking, but being present in a moment, is super important to predicting therapeutic effect. As Dr. Mathews indicated, there's a transient anxiety that can come on as the drug effect happens. And if people panic and don't know how to self-regulate or calm themselves, that can escalate into what's known in street terms as a bad trip. And that is determined normally by hours, not minutes of duration. That's the problem with a bad trip. And even those are often reported to be somehow therapeutically valuable, but we're not aiming for that. You're trying to reduce all of the risks so people feel safe enough to unfold. Positive language is really important. Clients who can speak positively about their opportunity to change and have new insights will do better. And then again, the older you are, and if you have previous experience with psychedelics, that's also known to help. So I'm just going to touch quickly on the concurrence of the death practice in psychedelics goes back to its origin. Tim Leary and Ram Dass, then known as Richard Alpert, wrote a book called The Psychedelic Experience, published in 1962. This was used as the first guidebook training psychedelic therapists in Mexico in 1963 and 1964. And what they did was they took the Bardo Tolol, which is the Tibetan Book of the Dead, and they saw that as a metaphor for the psychedelic journey. So in this way, all psychedelics are a death practice, because what people are experiencing is the death of the ego. Their normal sense of who they are, i.e. their ego, changes. And they see no substantive permanent reality to who they thought they were. The fact that we have ability to change our valence, our perspective on the world can change. So psychedelics experiences of multi-perspectivism. People can reappraise things that they thought were one way. They can see a different perspective. They can let go of things. So this kind of ego dissolution happens and has been used from the get-go, really, of psychedelic therapy as the core model, which is model of peak psychedelic experience. We're trying to get ego dissolution, feel of a new experience, of a new perspective. They can drop some past judgments on themselves or on others, move into new cognitive flexibility, have new insights and experiences of spirituality or depth or emotionality that had previously been repressed. So that's that kind of rebirth that's kind of at the core of this work. This is just a model for my thesis you can find, and it's just arguing that psychedelics are like a catalyst. They introduce a whole lot of new energy, and part of what they do is they open up thalamic gating. Because your brain is quieter on psilocybin due to the vasoconstrictive effects, the thalamus, which is all that effort we make to create models of the world, which we're basically inhibiting other information, falls apart, so the gate opens, and people have experiences of reality and perceptions that are different than the norm. That's a catalyst. And as people come down from that drug effect, there's persisting neurobiological changes, which by my model are periods of enhanced learning. So you can look at starting meditation practice, continuing breathwork practices, not drinking, new practices of relationality. People are generally feeling much more relational after psilocybin. They're forgiving of themselves and of others. They want to reconnect with what's important. And I will say that psilocybin alters valence, but also salience. What's important becomes clearer. Currently, however, it's all illegal.
Ronald,
yeah.
Ronald, sorry, it's Jose. I'm just looking at the time. Given the large number of people that have joined in, given the interest and the questions being generated, I think that we're going to really need another session again. I think there's a lot of interest. I'm saying this because we've got other panelists and we really want to hear from everyone. So perhaps if you're starting to wrap up with the key messages here, and then we can get a little bit from Kylea and a bit from Lyle and Geneviève. And then I think we're going to invite you folks back again, if you don't mind, because this is fascinating.
Yeah.
And I'm learning a lot.
So I'll just close on two things. And yeah, sorry, I think I didn't get started till later. The current legal and regulatory context, psilocybin is still controlled and classified as a Schedule 3 controlled drugs and substances under the CDSA. So in order to access it, people used to use what's called a Section 56. Now we have open to us the Special Access Program, which is available for novel therapeutics that may be available in other areas but not yet approved, or coming closer to regulatory approval, and that's where psilocybin falls. But it is still within that special access. People can sometimes get Schedule or Section 56 exemptions, but that is the mainstream. What people should know is MDMA will be legal in the United States within the year 2024, and it'll be regulated for medical prescription. Canada will quickly follow. So MDMA will be legal either later in 2024 or early 2025. Psilocybin is at least a year, maybe two behind it. So that's the order this is going to kind of go, but psychedelic therapy is coming. It will be legal within this year. I'll leave it there. Thank you.
Thanks very much. Excellent. Thank you. Let's carry on then to the next panelist presenter, and I'm just monitoring the questions, and then we'll come back to some of those. So Dana, could you advance the slides, please? Because I'm not having any luck.
Yeah.
Is Kylea, are you next?
Oh, I don't think there was a formal, it was just the two main presenters. So
Okay, perfect. So okay, well, so maybe what we could do then is let me just stop the screen and we can see the faces then. Perhaps Kylie, your thoughts on what you're hearing, questions, comments that you may have.
I will. Gosh, we could be on this for 5 hours today or more.
I'm sure.
So I guess I'll keep it to, if I have a brief moment to make a comment about it. This is a very special space, and what I would say is over the last several years, as I had been digging in and learning, and in the last bit, like going through formal training, one of the big appreciations that I have gotten from this is this work with these medicines needs to be done really, really carefully. And at the sites, I don't want to sound hokey per se, but there's a true sacredness to what can happen with these medicines. They're very opening. And so what I would emphasize is that there's a lot going on out there. There's been underground work. There've been really wonderful underground practitioners doing this work for years. There's, recreational use, and what can happen when people use these medicines, and it was being alluded to, they open us. Then they can really open people. And I want to emphasize what has been mentioned by the speakers is that what happens before the medicine session, what happens during the medicine session, the sense of safety is so important. That relationship is so important. Preparing people for what can come up in that session is so important, and there needs to be such trust. The people that I have trained with, and I've done some holotropic breath work, which is a non-medicinal way of creating an altered state of consciousness. This idea of the way out is through, when those anxieties, when very fearful things, because these are not all beautiful experiences, as Ron was saying, that we need to really work in good teams and each know how we contribute. So for me as a physician, at one point, I thought I was going to do the psychotherapy. And I will tell you right now, I will not be doing the psychotherapy, because that is such a special type of work that takes just as much years of experience as it took for me to become a physician. So I can facilitate, I can provide the environment for patients. I can, as a co-facilitator, as a co-sitter, I'm taking training to do that. I can prescribe, I have my space, but what I'm trying to do is develop teams of people so that we're delivering this in the best possible way. I think we can do this work now, but I think the trials will inform us. But I really need to emphasize the before, the during, and the integration after. That neuroplasticity that can open up. There is great space for change there. And you really need supported people and well-trained psychotherapists, doing this work. We need to do it in teams together very carefully and very safely. This isn't something to be taken lightly, but boy, I think even the collective experience, we change as people when we sit with others in this. So the self-care, if you're going to engage in this work, is very important. We could talk about so many things. Anyway, I'm going to stop taking up time and space. But I just want to emphasize that this is not something to be taken lightly. It's something we need to do, and we need to do it as well as we can together. So I'm going to stop talking so other really great people can comment.
Okay, that's fascinating. And I really am beginning to feel more and more there is another session being planned, and we might even need a third, because there are questions as well about what that mystical experience is like, or what do patients report. Perhaps at this point, I'll go over to Lyle and Geneviève, your insights, and maybe if you can build up on some of the things that Ronald mentioned.
Go ahead.
Yeah, I think I would probably reinforce everything that Kylea said. It makes me working with these medicines is really humbling as a physician, and we realize that I keep blanking in and out. It's kind of like a psychedelic experience for everybody watching this.
Yeah, just stay fixed right in front of the camera.
But yeah, this is so different from any other medications that we use in our normal allopathic Western medical practice. We're talking about consciousness changing medications in a really different sense from the way that benzodiazepines change consciousness or that opioids change consciousness. Those are tending to be more kind of dimmer switches and turning things down. Whereas, as Ron mentioned, these are non-specific amplifiers. You're getting everything turned up, and often things coming to the surface that have been buried for years. And I fear it being thought about as just another medication that we may be able to prescribe as physicians, and people doing this blindly, and bad experiences happening that shut down the process like happened decades ago. And so we're seeing things reemerge right now, and I think it's on us to be careful about it and to treat these medicines with respect and evolve this consciously and carefully so that for the benefit of future patients who can benefit from this. And I really feel that there's a big role for this in palliative medicine. And I'm by no means an evangelist or thinking that this is a panacea for everything that may ail people. And sometimes what you see in the media may put that spin on things. I think it's going to be another tool in our toolbox that we can use intelligently, but it's going to be a very different tool from most of the ones that we currently have. I very much agree with the need for this to be a team process and for people to be involved on an ongoing basis before and afterwards. That integration piece is so important.
Very good.
Yeah, and I don't know if I have a whole lot to add here, and we're closing soon. I think from my perspective, what we're trying to do in Ottawa is also look at leveraging the allied health professional workforce, because I think there's always going to need to be like a physician, obviously, oversight, looking at the prescribing and just the medical side of things. But I think we also have other resources we can leverage in terms of clinician support and time, a little bit like Kylea was saying with psychotherapy. But I think there's a lot of resources with the nursing workforce or social work workforce. I've seen some comments or questions in the Q&A where the role of spiritual care, where we're trying to build some space in Ottawa on the sort of palliative care unit. We have a strong volunteer workforce. Obviously, we are looking at training and struggling with training. Training is very lengthy, very expensive, very time consuming, rightfully so, probably, because you do need to keep things safe, but it's just finding that balance, because the way things are right now and with the cost, like there's no way we can support this at a larger scale. So these are the things I'm kind of involved in, but yeah, looking forward to hopefully get accepted to university, go back to school and learn more about this.
Thanks, Geneviève. I see Kylie's got a hand up, and Kylea, and then after you, there's a question there. I'm looking at the time, but perhaps if we could quickly answer the other question, what's the worst cases of long-term or short-term negative side effects? So Kylea, you respond to what you're responding to, and then if one of the other panelists could tackle the question.
Curiously enough, I saw that question.
Oh, cool. And you can answer it? Fantastic.
I can answer in part. I'm only one panelist, so I will say mine and then be quiet so others can comment. I did want to comment to the spiritual care. The Tony Bossis in the group in New York, there's a clinical trial keep your eyes on the literature. I mean, those of us that are already reading the literature, but for other of you that are watching this, they have done a clinical trial specifically based around spiritual care providers, and that should be getting published this year in one of the psycho-oncology journals. So we'll get some really great data on that, and they are such a key piece. So I just want to throw that out there. The short and the long term, yeah, so there you do need a solid medical assessment, because there are some drug interactions and things. There aren't that many. Psilocybin is quite safe, but there are some, and there are some medical contraindications and things. And if you have any concerns about the psychological or psychiatric aspects, again, if we're going to unleash and open in people that have psychiatric histories of schizophrenia, et cetera, there's study going on in that as well. In fact, if you go back to the history, looking at psychiatric disorders is how we even had LSD. So it's all very interesting. So there may be a role for that. But I think right now, to be as safe as we can, a really good assessment by someone who is familiar with these and trained with these as a physician is important to keep it as safe as we can for patients. The short and long term is also, again, to the points that we were making. When we open people, you can have things that are called spiritual emergencies that can arise with this. And this comes when we don't do enough integration, when there's not enough sense of safety that goes on in the session. And I think one of the biggest pitfalls that we are seeing is lack of good integration, or not good right relationship between therapists and clients. And I would refer people to Kylea. Her name's actually spelled like mine, but she says the A. Kylea Taylor has written a beautiful book called The Ethics in Caring. If you look her up, Kylea Taylor, anybody that wants to get involved in this work should really be reading her book. Consider taking her courses, because it gets us very grounded and focused, because the danger is definitely if we don't integrate, if we don't support, if we don't work together and provide the right thing, that's where we can create things. Imagine opening somebody and all of these things coming up and then them not knowing what to do with it with themselves. So those are some comments, and I will be quiet now.
Oh, fantastic. Thank you so much. Well, we've reached the end of the session. There will be a message going out for another session on the topic, I see. To our presenters and panelists, thank you so much. Ronald, thank you so much. Jean, Kylie, Geneviève, Lyle, thank you for joining us. Thank you for sharing your insights. I've learned a lot. I'm sure a lot of people have learned a lot. And maybe next time we can tackle the question about that someone asked right at the beginning, what is the definition of existential? I think there's a lot of overlap between that and spiritual, but we can tackle another time. Thanks, everyone. And again, just to remind you that you'll be getting an email, those registered, with a link to the presentation, so you can go through it slowly in your own time. And within a few weeks, it'll also be available on the Pallium ECHO website. So do share it with colleagues and spread it further. And to the Pallium team for supporting this, thank you very, very much. Bye, everyone. Thank you.